On the same patient, in the maxillary arch, we had an area of recession generalized on both the posterior left and right sides, including the central incisors. An attempt was then made the same day, because this patient was going to have some cosmetic dentistry performed, veneers and crowns, to augment the soft tissue prior to restoration. We utilized a combination of alternating tunnel and full thickness flaps. And you're seeing here the utilization of a tunneling instrument, a modified Orban, to tunnel the soft tissue for the soft tissue graft. Alloderm, again, a 2x4 piece of alloderm is utilized and cut in two pieces, and we're able to utilize one piece for the right side and one piece for the left side. And you can see that we've alternating the tunnel in this case, the midline, each papilla, and then lifting this papilla between the lateral and canine, and then tunneling as well in the posterior bicuspid area. The alternation and alternating of these tunnels and maintaining one papilla and lifting the other really facilitates the ability for us to move the tissue, whether it be alloderm, dermis, or autogenous tissue, through the tunnel. If you attempt to do this tunnel all the way through, it makes it not only very difficult and challenging from a surgical standpoint, but it makes it very difficult to actually pass this tissue all the way through this tunnel without being able to access it periodically. I like to soak this alloderm whenever possible, as I said before, into a bioactive modifier. There have been some people talking about also utilizing tetracycline for 3 minutes with sterile water to impregnate this material with tetracycline. I believe Lee Silverstein has published on that. You can do that. I happen to be a big fan and advocate of it, as well as following that up with the utilization of a bioactive modifier, whether it be PRGF, which is my preference, autologous, or if not, then a GEM21 for a period of 10 minutes. We then went ahead and used a tissue packing instrument to move the alloderm into the tunnel. As you can see, as I said before, moving this material all the way across, this ability to retain a couple of papillas and then open up the third one here allows me to get access to the alloderm to then pass it and continue to pass it, as you see on the right screen, all the way through to the first molar. We're going to do the same thing on the right side with the additional piece of alloderm. So one of the nice things about the alloderm material is that one large piece and you can really do almost an entire arch of tissue grafting. The day of surgery, as I have said earlier to you, my preference is to utilize a sling mattress suture and to coronally position the outer flap entirely over the alloderm material. It is very important whenever you're using allograft products or xenograft products, I believe, to completely maintain closure over the top for your best results. That doesn't mean that if you don't attain complete closure throughout healing that you're going to get failure, but certainly your improved success if you're able to attain and retain closure of the material. This is the day of surgery on the left side. This is at approximately 10 days to 2 weeks where I take the sutures out, and you can see we've been able to maintain closure of the outer flap over all of the alloderm that's been placed. It's very important with alloderm that we wait at least a period of 4 to 6 months for maturity and replacement and integration of that tissue with the host tissue. With autogenous tissue, I believe you can wait less time, maybe 2 to 3 months, because that tissue is vital. It retains its vitality as opposed to alloderm, which is a non-vital material. And if you take a look again at the preliminary view and then the view at approximately 4 months, you can see we've attained a very, very nice root coverage over most of this area, and also a thickening of the soft tissue, removing the clefts and the recession that had been there previously. This being all done in one sitting and being done from molar to molar. If we take a look at the impact from a smile standpoint, smile aesthetics, you can see when she previously smiled, she had areas of root exposure that were discolored and yellow, that had gone up beyond the lip line, changing the proportions of the teeth. For the restorative phase, this would have been challenging. Where to end your margin, what type of shape tooth and proportion tooth would have been difficult for the restorative colleague. So I think pre-prosthetic or pre-cosmetic dentistry periodontal plastic surgery like this obviously idealizes not only the soft tissue line, but also enables the prosthodontist restorative colleague to have better tooth proportion for the final restorative phase. If you then go to the next challenge for us, really, it would be, again, the idea of how to maintain crestal bone and how to deal with the challenges of implant therapy in the maxillary anterior region. Much has been said about tooth extraction in this area, whether we should do immediate implantation or staged implantation, and what exactly happens in the socket environment. I think one of the things that has over the last few years become more of a priority in aesthetic tooth replacement has been the importance not only of tissue maintenance, but of tissue color. So yes, we do need the tissue to be retained. We want to maintain the interproximal peaks of tissue, the papilla, but long term, 1 year and 2 years out, we want to know that the remodeling that takes place of this bone will not complicate or compromise the aesthetics from a color standpoint. As some cases we get remodeling of that labial bone in the area where we place the implant, causing a bluish or darkening of that soft tissue over the future implant restoration. Back in 1993, my brother and I published an article in the International Journal of Perio and Restorative Dentistry, which was really highlighted a systematic approach to the management of extraction site defects. And what we talked about during that article was that it's very important for us to ascertain the location of the bone available around the tooth that's going to be extracted. Not only the labial bone, but also the interproximal bone. I think that these measurements can be attained. Back in 1993, they were attained solely through PA x-rays and bone sounding with a probe. Today, obviously, we can use cone beam imaging technology where we can actually extract the tooth on the software and evaluate the remaining bone around the socket. So today we have really great technology to be able to do that. What we said back then is that it was very important prior to extraction that we understand the anatomy below the gum line. I think we all can understand that this has really become more and more of an importance in the aesthetic zone, and there's been more information that has been published in the literature since 1993 on this very subject. The location of the labial bone, the presence of the interproximal bone on the adjacent natural teeth. The location of the interproximal bone on the adjacent natural teeth is of the utmost importance for the preservation and aesthetics of the interdental papilla. Not the location of that bone around the implant, but that on the adjacent teeth. So when we're focused just on the labial plate or the bone around the implant and we're not looking at the adjacent teeth, we sometimes can have a misdiagnosis and we could end up with soft tissue problems. In 1993 and back in 2000 and 1998, we published an additional article in the Practical Periodontics and Aesthetic Dentistry Journal, where we talked about the importance of the interproximal bone. We talked about 3 classifications of the IHB. A class 1 where we have an ideal prognosis, a class 2 where we have horizontal bone loss of 1 to 2 millimeters, where we have a guarded prognosis, and a class 3 situation where we have a concavity interproximally, where we have more than 7 millimeters of bone loss, and where we have a very poor prognosis for aesthetics and tooth replacement. So therefore, when we look at this from an interproximal standpoint, we have to understand our limitations. On the labial aspect, how much bone do we have located on the facial aspect? And that also leads us to the appropriate diagnosis and difficulty. We can either have ideal bone on the labial, where we've lost no bone, which would be a class 1. If we lost 2 to 3 millimeters of labial plate, a class 2. Or if we've lost more than that, then a class 3 environment. So the labial and the interproximal classifications are very important to understand before you proceed with the procedure. As we get into class 3 defects, my tendency, I can tell you in the audience, is that I prefer a staged approach. I like to graft it with bone, maybe tissue, and then reevaluate after healing. In the class 1 approach, class 1 defect, where we have the bone, I prefer an immediate response, where we can take the tooth out and place our implants immediately. The area where I think a lot of discussion is and controversy is in the class 2 individuals, whether to place the implant and graft around the implant or to stage the case. And I really still believe that that's somewhat controversial. I think each one of us would manage those situations somewhat differently. So a lot of different ways for us to manage these situations. Let's take a look at this patient. One of the things that I think that we should do with tooth replacement in the aesthetic zone is to also locate the CEJ of the adjacent natural teeth. And in this case, this young lady had a little bit of gingival hyperplasia. She had a little bit of excess gingiva after orthodontic treatment, and she did not display all of her clinical crown. And when we're looking at this, a lot of people would say this is an altered passive eruption case, a type 1A, where we have easily that we can remove the gingiva from this area down to the CEJ. And the reason I like to do that is if you don't locate the CEJ, you're going to place the implant too coronal, and will make it for a difficult situation later on. So I prefer to do this simple GV down to the CEJ with a radiosurge tip. This is from Elman's. I use a cut coag setting of approximately 6, and I use a little micro tip. Makes it very easy. I always use this with a wet field. So I like to take a damp gauze before I use the Elman's unit. I just wet the tissue before I make my incisions. Once I do the gingivectomy, I then raise the flap. Now this is important that you raise the flap because if I have to do any minor crown lengthening, of osseous crown lengthening, I can take care of this as well. So if the bone is too close to the CEJ, what you're going to end up is with rebound. So you need to understand in some cases, and in this case that was such the case, where we had bone within 1 millimeter of the CEJ, if I don't go in there and reduce that bone on the labial, then that tissue that I cut away has a tendency of rebounding. And since I don't want that from an aesthetic standpoint, I want to retain the CEJ position of my gingivectomy, I go ahead and I do some minor ostectomy and scallop the soft tissue, as you see, scallop the hard tissue, as you see here, to follow the rise and fall of the soft tissue. Now we're left with a fractured tooth that is hopeless, and we have to remove it. A lot of different ways to remove these teeth these days. Obviously today we're talking about tools and technologies that are available. Periotomes, I really prefer to utilize periotomes in engaging the periodontal ligament space on the mesial, distal, and palatal aspects. I like to leave the labial bone completely alone during my attempt to extract the tooth. There are some new technologies available today for tooth extraction, many new technologies. Some that I'm in favor of is Easy Extract by A-Titan, which actually goes into the root canal system of the tooth and pulls the tooth out utilizing vertical force. The Bendex system as well utilizes a pulley system, also very, very easy for single roots. These techniques work very, very well. Piezosurgical tips now with periotome tips that can be utilized in the same way, utilizing ultrasonic surgery, piezoelectric surgery, by going into this space and making very, very fine cuts into the periodontal ligament as we go down the tooth. Once we're able to do that, you can see that we can maintain and preserve even this thin labial bone, and you can see we also have been able to maintain and preserve the important interproximal bone on the adjacent natural teeth. I think it's very important that once you extract the tooth, that you reevaluate your extraction site before going ahead with implant placement. And many times I tell my graduate students that the extraction of these teeth should probably take you twice as long as the actual implant placement. You should be very careful, taking your time and making sure that you really do not place any pressure on that labial plate of bone. The extraction site, what are the limitations when we're looking at these situations? Well, invariably, don't place any pressure on that labial plate of bone. The extraction site, what are the limitations when we're looking at these situations? Well, invariably, don't place any pressure on that labial plate of bone. The extraction site, what are the limitations when we're looking at these situations? Well, invariably, don't place any pressure on that labial plate of bone. The extraction site, what are the limitations when we're looking at these situations? Well, invariably, don't place any pressure on that labial plate of bone. The extraction site, what are the limitations when we're looking at these situations? Well, invariably, don't place any pressure on that labial plate of bone. The extraction site, what are the limitations when we're looking at these situations? Well, invariably, don't place any pressure on that labial plate of bone. The extraction site, what are the limitations when we're looking at these situations? Well, invariably, don't place any pressure on that labial plate of bone. The extraction site, what are the limitations when we're looking at these situations? invariably not place any pressure on that labial plate of bone. The extraction site, what are the limitations when we're looking at these situations? Well, Invariably, the area that we're most concerned about is going to be right on the labial aspect of the head of the implant. We're going to go ahead, in this case, we're going to be placing an ankylose implant in this area. And when we start to place this implant, one of the things we're focused on is what's going to happen to this very thin labial plate of bone. We're pretty certain today, based upon the literature, that if we start the process of restoring an implant, and really if you look at the literature from Cochrane and Herman, the effect of the microgap and biological remodeling, just being able to engage this for the prosthetic component, we end up getting some remodeling. So this little bit of bone loss that you're seeing here is something that we can consider just simply from placing an abutment to that connection. Now, some of the implant designs today have hopefully minimized that remodeling, but according to the literature, just adding a restorative component has some remodeling effect on the crestal bone. If we take a look at the design of the implant, we really today, if you look at this implant being inserted, I prefer to place my implant 1 to 2 millimeters lingual to the labial bone that's available, leaving a space, so I never engage that bone with the threads or with any of the drills. In addition, I never place my implant down the apex of the tooth that was extracted. What we really want to do is use the same angulation, but what we want is to place the implant 3 to 4 millimeters up from the lingual wall of the apex of the tooth that was extracted, and use the same angulation but going lingually. What we want to do is first place a purchase with a round drill. Then we want to go ahead and stay to that lingual, avoiding entirely any contact of the implant with that labial plate. And you can see this is what we've done diagrammatically on the left side, and on the right side what you're seeing is this very case with a stereolithographic, with a barium sulfate guide, the implant being inserted and staying away from the remaining labial plate of bone. So this is what it would look like from a schematic rendering, and this is really something that you can see that we're doing in the mouth. My preference again is to stay towards the lingual. You can see this very important interproximal peak of bone being maintained and preserved, and you can also see that this thin labial plate of bone has been very, very carefully avoided during the placement of the implant. So today, if I had to make some points about implant placement, which I think is so important, I think it's very important whenever possible that you place your implant 1 to 2 millimeters lingual to the labial plate of bone. I think it's very important that if you're placing it, that you want, whenever possible, lingual screw access, or cingulum access to your screw, so that you have the option of doing either screw retained prosthesis or cementable. Another thing is, in terms of depth placement, my preference is to place the implant 2 millimeters or no more than 3 millimeters apical to the future location of the margin of your restoration. So again, if we look at this schematically, taken from a cross-section on the CT scan, we want to stay at least 2 millimeters from the labial plate of bone. And when we place our abutment, this is now the next stage of what we're really focusing on. If we're going to preserve this bone on the labial aspect, then moving the connection of the abutment towards the middle of the implant, something called platform switching, has been a very hot topic in dentistry. And since the nature of our discussion today is new techniques and technologies, we definitely have to spend some time talking about the concept of platform switching. If we look at this abutment system from ankylose, you can see that their abutments have a built-in platform switch concept. Platform switching just simply meaning a smaller diameter prosthetic component to the diameter of the implants that was placed. Basically, this is moving the connection horizontally away from the bone, and the theory behind that is possibly maintaining and preserving this very important bone at the top of the implant. So if we're going to be placing our connection of this abutment away from the outside of the implant, we may in fact gain an advantage in terms of remodeling from a biological width aspect. I happen to be a big fan of reducing the size of the prosthetic components. I think that it makes a lot of sense, and some of the early literature and some of the early cases that have been displayed appear to substantiate some of these concepts. And we will continue to monitor and watch these things. I think collectively, bringing the macro and micro geometries of the implants together, maybe closer to the top of the implant, and then adding micro channels, micro grooves, laser channels, as well as some form of platform switching, rigid connections are all things that are helpful in maintaining that important piece of crestal labial bone. So if you take a look at this patient, again, we're now testing what a permanent abutment would look like in place. This is a anterior balance abutment or an aesthetic abutment from ankylose, the Dentsply. And you can see the sloping shoulder that's anatomic in nature for an anterior central incisor, but it has a significant platform switch that engages the top of the implant. These implants are usually placed subcrestally by at least 1 to 2 millimeters. We've got to make sure of that. And therefore, this area here has diminished space, allowing room for the establishment of a blood clot and then invariably the remodeling with bone and connective tissue. Now, one of the other issues I talked about earlier with you in the beginning of this webinar was a case that displayed, unfortunately, some of the things that occur after we place implants, especially in autogenous bone, unpredictability of bone remodeling that may ensue. What we do in cases like this is that I prefer to use a xenograftic product to reduce the autogenous bone resorption on the outside of the labial plate. So inside the socket, I had suggested earlier that I prefer a high turnover product like irradiated mineralized allograft bone. But on the outside of the socket or in the sinus, I prefer to utilize a xenograftic product or a mixture of xenograft 50% to corticocancellous bone 50%. And in this case, I was using PepGen, a product that has a low turnover, that does not resorb quickly, to help preserve this labial plate of bone during the healing phase. We used a balanced healing abutment. This is at the same shape as the permanent abutment. It's identical, so when you take this out, it maintains the shape for the future permanent abutment. What you're seeing here on the left screen is approximately 10 days of suture removal. You can see that we've hiked the tissue over the top of the healing abutment, the balanced healing abutment. And then approximately 10 weeks on the right screen, you can see that we've been able to maintain the height of the interdental tissue as well as the thickness and contour of the labial plate and ridge. And this is extremely important for aesthetics. Now these pictures really start to tell you why platform switching and vertical bone maintenance may in fact be enormously important and powerful as a tool. What you're seeing on the left screen is with the balance abutment in place, you can see the balance healing abutment, you can see that bone actually grew over the top of the shoulder of the implant. This is something that is possible. I don't believe what we're seeing may in fact be or may not be osseointegration. Today, with the Cell Plus surface, with the ankylose system offering the implant microgeometry going over the shoulder of the implant, the opportunity today to actually get some osseointegration over the top of the implant, the lip of that head of the implant, may in fact be something that is possible and that retains the bone for tissue stability and aesthetics. On the right screen, what you're seeing is when we transfer the healing abutment to the permanent ankylose balance abutment, anterior balance abutment, you'll see that the same platform switching is matched with the final abutment. Here's the aesthetic form to this abutment, but we have a substantial amount. This is a 1-year post-op, and you can see that this bone has been preserved over the top of the implant. So we're really looking at something that may be a very significant key to future aesthetic restorations. Some form of platform switch concept may in fact assist us. What we're seeing here on the left screen is maybe the ability to use the same concept for placing two implants close to one another. As you see here, a central and lateral implant. Maybe using platform switching allows us to gain more horizontal space. And Dennis Tarnow had said 3 millimeters, but maybe with platform switching, you can actually give yourself even more distance by not having the horizontal components so close together. the concept seeing on the middle screen. Obviously, we can't do it as easily with normal implant designs because the prosthetic components go all the way out to the sides of the implant. So from an abutment selection standpoint, a balanced contour abutment really allows us to have the natural aesthetic contours of restoration. We also have the ability to utilize either titanium or zirconium. And on top of that, we have a significant platform switch. You can see here the different zirconium products and the different lengths depending on how deep the head of the implant is. And we also have a titanium option. We have a natural scallop to this restoration, so it mirrors the normal anatomy of the underlying bone in scalloped form. Now, one of the things that is necessary, well, used to be necessary, but today may no longer be necessary. The old ankylosing system was a non-index system. Today, they have an indexed option. But in the old days, we would have to utilize a jig to place these abutments to make sure that they line up with the future restoration. Now, here are the zirconium anterior balance abutments that you can choose from. Once you select the appropriate one, we then utilize a ceramic coping that would then be utilized as a pickup impression. So today, we may no longer need this, as we now have a ankylosing product that you can either have as a non-engaging, a non-indexed version, which is the version that's been around for many, many years, or just recently added to their product mix is a actual indexed option with the ankylosing system. Here is the zirconium abutment, the balanced zirconium abutment finished in the laboratory. It's going to be a cementable restoration. We make sure that the laboratory keeps this margin no more than 0.5 to 1 millimeter deep on the labial aspect, and no more than 1 to 2 millimeters deep into proximally in terms of an easily accessible cement line. The temporary restoration in place, and you can see us leaving space for the soft tissue to fill, and this is after approximately 3 months. In our office, we like to leave the temporary restorations in for at least 3 months to give the soft tissue enough time to fully mature before going on to the final soft tissue restoration. And then, of course, as you see here, the x-rays of the final restoration in place. And then this young lady, full smile. This is about a 1-year post-op, maintaining the intact interdental papillas, the labial soft tissue, and of course the color of the restoration. When we showed you a few cases that many of you would say maybe be a little bit on the rather easier side, and now we're going to go to, I think, a more difficult case types. And the type 3 restoration, which I think is always a challenging restoration, and in the time that we have allotted before questions and answers, is that we have defects, as you see on the left screen and the right screen, that may be substantial in terms of the vertical bone and soft tissue loss. On the left side, we have a missing right central incisor with bone loss on the adjacent lateral incisor interproximally and facially, causing a aesthetic deficiency. On the right side here, you're seeing 2 periodontally involved teeth that have lost soft tissue from recession, as well as a substantial amount of interdental papilla. The description of a type 3 would be one that includes interproximal vertical bone loss and soft tissue loss. And the treatment focus is grafting. We may have to include some form of pink restoration, artificial gingiva, maybe distraction osteogenesis, onlay bone grafting. The focus is on vertical augmentation. So let's take a look at this case, the type 3 defect. And what we're going to do is just pause for a few seconds to really identify the challenges in a case like this. Left central incisor. On a close-up view of this area, you can see the patient has a high smile line. This patient had previously lost an implant in this area and had been grafted with a xenograftic product in the socket approximately 6 months ago. And you can easily see that this product has a low turnover. It's easily distinguishable from the adjacent host bone. And this is something that I tell you, as I said before, I prefer not to utilize in an area that I'm going to go back and place an implant. I prefer a high turnover product. So this clearly shows you with a xenograftic product, even at 6 months, that it's still not resorbing.